Sound check, sound check. All right, folks, it's Professor Gulliford here. This is part 3 of our 2017 TMC review sheet video. This is where we're going to cover the last 50 to 60 items of the TMC review sheet with you. This is part of a series. You should already have part 1 and part 2 of this video. If you do not, send an email to me, Deryl.Gulliford, that is DERYL.GULLIFORD at independence.edu, and I will get you those links immediately. All right, here comes part 3. We're going to do a screen share the desktop, and sound, and optimize video. Okay, that should be screen sharing, and here is the review sheet. So let's go ahead and get that to a size that you can actually use, and we'll close out anything that's taking up space here and go to a one-page view. And how about a little bit bigger so you can see it better? Okay, we left off the second video, the part 2, at item 205, I believe. So let's get down to that level. When I created the first video, I never had an idea that there would even be a second video, let alone a third video. But we continue to learn more about the key topics that are on the TMC exam, the things that you really need to review. And because of that, we obviously need to extend the video. Here we are at number 200. I remember this item, and I think this is the last item that we actually covered, which was the neuromuscular blocking agents. Quite a few students have seen questions about that. We don't know what your exact question will be, but it's useful for you to know that succinylcholine, which we just call it SUX, S-U-X at the hospital, succinylcholine is the only depolarizing neuromuscular blocking agent. The others, and certainly you've heard of rocuronium, they call it rock, and it is a non-depolarizing. Succinylcholine depolarizing, rocuronium non-depolarizing. Pay attention there to the onset, which is about 30 to 45 seconds, and the duration of action, which is 30 to 45 minutes for rock, but only 4 to 5 minutes for succinylcholine. So that's very useful. If you need to paralyze the patient just long enough to intubate, succinylcholine is sometimes considered the best choice. All right. Just take a look at that whole chart. But the points that I just made about rocuronium and succinylcholine are probably the most important items. Also, so important, anytime that you paralyze the patient, you must sedate them with something. You certainly wouldn't want to paralyze the patient and leave them completely alert to just lay there and not be able to do anything. So propofol is a good choice for that. Diazepam is Valium, time-honored approach. Certainly nothing wrong with using that. And lorazepam is Librium. So any of those would be a good option. A respiratory therapist would not be expected to need to know the dosages on those. All right, albuterol allergy. If the patient's allergic to albuterol, then probably they're allergic to levalbuterol also, which is unfortunate because levalbuterol is a very useful medicine. That's Xopenex, as you know. But you wouldn't want to give that patient who is albuterol allergic levalbuterol. You wouldn't want to do that because they're probably going to have the same reaction. You might recommend ipratropium, for example, or some other type of bronchodilator, a completely different class, chemical class. Air entrainment ratio is very important. The easy ones are 60% oxygen, which is a 1-to-1 ratio. I hope you get that on your test. That would be awesome because you don't have to do any calculating. 40% is also pretty easy. It's 3-to-1, and 35% is 5-to-1. I'll bet you get one of those. But let's explain how to do this. For each liter of oxygen flow, this chart provides the flow of air which is entrained at the various FiO2 settings. This is helpful in determining the total flow to meet the patient's inspiratory demand. You can calculate these. Let's say you get one that's not easy to remember. Let's say, let's go with, let's do 40%. For example, 40% oxygen, you would take 100 minus 40, that's 60, over 40 minus 20, that 20 is representing room air, so you'd have 60 over 20 for an air entrainment ratio of 3. So if the oxygen flow meter is set at 10, then the airflow is 30 and the total flow is 40. The thing you need to remember here is to, after you have calculated the airflow, the air entrainment, you have to also add in the oxygen itself. So in this particular case, as long as the patient's inspiratory demand is less than 40, we're good to go. Right? That's air entrainment ratios. Take 100 minus the oxygen percentage, divide that number by the oxygen percentage minus 20. That gives you the ratio, tells you how much air is drawn in, and then always remember to add in the oxygen flow also. Moving ahead, theophylline, yeah, theophylline has been mentioned on the test. Quite a few students came back asking about theophylline. And one thing you definitely need to know is that it is used in very small doses to stimulate breathing in kids with apnea of prematurity. You could use either caffeine or theophylline. I've always thought it's kind of funny that these little kids get their first cup of coffee before they're even out of the NICU. We can give them caffeine or theophylline, but either one just stimulates them and makes the apnea less likely to happen, less severe. So theophylline is given to infants with apnea of prematurity. It's also a xanthine bronchodilator that we sometimes use in adults. The problem with theophylline has always been a toxicity. By the time we get the theophylline level high enough to be effective, it's almost to the toxic level. The safe therapeutic level, this is, I think, a fair question to ask, is 10 to 20. The safe therapeutic blood level is 10 to 20 for our adult patients. Okay, what type of mask should be used to deliver oxygen during non-pressurized air transport? That would be like a helicopter, fixed-wing airplane. Definitely you want a non-rebreather up there, because with altitude, you don't really know exactly how much oxygen the patient is getting if you use a cannula or a simple mask or something like that. So definitely non-rebreather mask for altitude transport. Defibrillators and cardioversion settings. We're running into this on the exam. Students are coming back and saying, wow, I wish I'd have studied the defibrillator more. So you can study the defibrillator right here. A biphasic defibrillator, which is the modern version. For VFib or pulseless VTAC, you start with 120 and go up stepwise then to 200, 300, and 360 joules. You start at 120 and go up to 200, 300, and 360. So that's for defibrillation. For cardioversion, it's a lower amount of electricity which is needed. We're going to sync on the R wave to cardiovert the patient. For atrial fib, it's 120 to 200 joules. For atrial flutter, 50 to 100. And for VTAC with a pulse, just 100. Those will very likely convert the patient back to a better rhythm. The settings are higher for the old monophasic defibrillators, but I don't think you're going to have that on the test. It would be odd for you to get a question about an outmoded machine on the test. So if you will pay attention to those numbers for the biphasic modern defibrillator, I think you'll be in good shape. Number 211 is an important item. Several students were asked about pertussis. Well, pertussis, as you know, is whooping cough. The isolation is droplet precautions. The isolation is droplet precautions used to prevent contact with mucus and other secretions from the nose, sinus, throat, airways, and lungs. All right. This is the same type of isolation that you would use for true influenza, and also mumps, by the way. But whooping cough is one that you definitely will see, and it's droplet precautions. When I had that question from several students, it occurred to me that we might want to just go over isolation precautions in general. Obviously, you've got your standard precautions, which includes gloves, masks and goggles, aprons, gowns, shoe covers. Properly clean up afterward, also very important. But then you've got your transmission-based precautions, and let's just cover those quickly. Airborne is needed for germs so small they can float in the air, and that would be the classic tuberculosis, also chickenpox and measles. Tuberculosis is the one you will deal with at the hospital, and it is airborne precautions. Contact precautions, the classic example is Clostridium difficile, C. diff. You've heard about it from your very first day at the hospital because it's such a problem. Contact precautions for C. diff, and norovirus also. And then droplet, I already mentioned, is influenza and whooping cough. Position of the ET tube. All right, I think I put this in the discussion area. If not, I will be sure that I do. Let's take a look at that tube. Find the carina. This x-ray shows you pretty well where the carina is located, where the trachea divides into the right and left main stem. And then look at the tube position and say, is that about right? Or would we want to advance this, or would we want to pull it back? The answer is this tube's in good position. This tube is about 3, maybe 4 centimeters above the carina. It's well below the vocal cords. This is a well-positioned tube. You could have an x-ray on your test where the tube is too close to the carina. You could have one where it's too far up toward the vocal cords, but this one is in good position. How about a chest x-ray with an elevated white count? Let's look at this. This patient has an elevated white count, and they have this chest x-ray. Well, first, what do you think that x-ray shows? I'll give you just a minute. It certainly is pneumonia. Looks to me like a middle lobe pneumonia, and you would use antibiotics to treat this pneumonia, obviously. Number 215, calculating the PaO2, that's the big AO2, which is alveolar, and the AA gradient. There's a shortcut. I'm so happy to be able to give you this shortcut. 7 times the FiO2 minus the PaCO2 plus 10. If you haven't been given that shortcut formula yet, that's the one I would recommend for your test because it's easiest to remember. Just 7 times the FiO2 minus the PaCO2 plus 10. That will get you close enough to answer correctly for your test. So let's say the patient's on pure oxygen, which normally is what we do for doing this test for the big AO2 and the A gradient. The CO2 is 70, the PaO2 is 120. So you just take 7 times 100, that's 700, minus the CO2 plus 10, that's 80. 700 minus 80 is 620. That's the big AO2. But don't stop there. If you're going for AA gradient, then you need to subtract the oxygen, the PaO2. 620 minus 120 is 500. Take a minute and be sure you really know how to do that. 7 times the FiO2 minus the CO2 plus 10 gives you the big AO2, and then subtract the little AO2, the arterial oxygen, to get the AA gradient. That could very well show up on your test. The good news is students consistently are coming back and saying they did not have many calculations on their test. That's a good thing for you because you don't want to have to memorize 25 formulas. Well, you can't memorize 25 formulas. But this one is worth memorizing, this one right here. How about tidal volume from frequency and minute volume? The patient's minute volume is 10 liters per minute. Respiratory rate is 30. So to get tidal volume, we simply divide minute volume by frequency. 10 liters per minute divided by 30 breaths per minute gives you 333 milliliters for tidal volume. That patient is probably getting close to being able to be weaned. But again, to figure tidal volume, if you've got minute volume and frequency, you just divide. 10 liters divided by 30, that's 10,000 milliliters, gives you a tidal volume of 333. How about a patient with straw-colored sputum with protein in it? Patient has lost weight in the last 2 months. What diagnostic procedure would you recommend for this patient? It's definitely bronchoscopy. The weight loss That straw-colored sputum with protein makes you think lung cancer. We don't know if it is or is not until we do the bronch, but that's what you would certainly recommend. Crepitus. Numerous students have had crepitus on their test. I don't know what the exact question is, of course, but it has to do with having air in the soft tissue. When you have air or gas in the layer under the skin, then you have crepitus. Often there is an underlying pneumothorax that is causing this. It could be other things, but often that's the case. You push on the skin, you get that crackling or Rice Krispies feeling and sound from the crepitus. Some examples, it would be gunshot wound, a blunt trauma. Gas gangrene is unusual, but does in fact happen. Next item, we're on to 219, the single breath DLCO test. What does it tell us? Diffusion capacity, which can be decreased in a variety of obstructive and restrictive conditions. If you lose lung parenchyma, like emphysema, where you've got actual destruction of alveoli, that will do it. That will reduce the diffusion capacity. And anything that scars the lung, like interstitial lung disease, pulmonary fibrosis, swelling of lung tissue like pulmonary edema can do it. Diseases of the blood vessels in the lungs can do it. Probably the most common that we see, emphysema and pulmonary fibrosis. But anytime that the diffusion capacity is decreased, there is a reason, whether it's obstructive or restrictive. Sterilization indicators, here's a problem for getting ready for this test. RTs used to sterilize equipment a lot. We were constantly using Sidex and ethylene oxide and gas sterilizers, but we just don't anymore. It's almost all disposable equipment. So please review this about the various types of sterilization, the indicators which prove to us that the sterilization worked. You have mechanical indicators, chemical indicators, biological indicators, and that's the one that I want to talk about because students have seen this on their test, okay? So you have actual spores, bacterial spores, and those are included in a little container with the instruments to be sterilized. If the sterilizer worked, then when we incubate those spores, they will not grow because they have been killed. So that is a great positive way to know that the sterilization process worked. We've got a little container that includes spores of the bacteria, and they're usually bacillus species because those are spores and hard to kill, all right? That goes in with the instruments that are being sterilized, and then we incubate that little container. It probably won't grow because our sterilizer is pretty good. It probably worked. If you did see growth, then you would need to stop those instruments from being used because they were not completely sterilized. All right. And let's see here. Just read through there a little bit about spore testing. If it's positive, you need to immediately take the instruments out of use. Okay. That's an important point. Let's move on to skin turgor. Skin turgor is pretty interesting. You pinch the patient's skin, and if it's normal, it rapidly goes back into position. There's a very good picture here showing how this works. Patients with poor skin turgor take longer for the skin to go back to normal position. Lack of skin turgor occurs with moderate to severe fluid loss, dehydration. For the purpose of your test, you can consider poor skin turgor to be dehydration. All right. Test your own skin. You're going to notice that when you pinch it, it goes back very quickly to its normal position. But in dehydration, we see poor skin turgor. Breathing patterns, you could see any of these on your test. Let me mention the ones that students have already seen. Tachypnea, of course, is just rapid breathing. That's at the top left. And bradypnea, slow breathing on the right. Apnea speaks for itself, no breathing, right? Students have seen Shane Stokes breathing on the test. This is where the respiratory volume gradually increases and then decreases, and then there's a pause. Increases, decreases, and then there's a pause. That's Shane Stokes. You very well could see that on your test. Biot's breathing is a neurological type of breathing, indicates a neurological problem. Haven't actually had any students comment about that one. Kussmaul's you definitely could see. That is the rapid, deep breathing pattern of diabetic ketoacidosis, the rapid pattern of ketoacidosis. So you could see Kussmaul's. So just take a look at all these, but those are some that you definitely need to know. Normal urinary output, 1 milliliter per kilogram of body weight per hour. So it's an easy number to remember. Normal urinary output is 1 milliliter per kilogram of body weight per hour. So they might give you a patient who's producing less urine than that. Well, they're retaining fluid somewhere. You know, maybe it's going into their lungs, maybe it's going into soft tissue. More urinary output would indicate something producing a diuretic effect. When we give the patient Lasix, we want to measure their urine and see that it is increasing, so we are removing fluid from the tissues and lungs. The signet ring sign. Several students have mentioned that they had this on their test. It's in a CT scan. With a CT scan in a patient with bronchiectasis, you will see these rings that really do look like signet rings. That's what a signet ring is. If you wondered what the heck a signet ring actually is, there's a picture of it. But you can see these on the CT scan, and that is bronchiectasis. Signet ring is bronchiectasis. Number 225, CT scan and lung cancer. I just wanted you to understand why we are so adamant about getting a CT scan when the patient has symptoms that could indicate lung cancer. Look at the chest x-ray on the left. If you can see that lung cancer, you're better than me. Just don't see it. Same patient, CT scan, there's the lung cancer. It clearly is evident. So chest x-ray is not good for finding lung cancer. It usually finds lung cancer so late that we're not able to do much for the patient. So you would strongly recommend CT scan if there is a indication that the patient may have cancer. 226, the boot-shaped heart. This is tetralogy of Fallot. It's a classic finding. And if you look at that heart, it does in fact look like a boot. Certainly doesn't look like a normal heart. And that is tetralogy of Fallot. That is a combination of heart defects in infants that has to be fixed. It became famous just here within the last couple of months because Jimmy Kimmel, I had to think for a minute, Jimmy Kimmel, the famous television nighttime host, his baby boy had tetralogy of Fallot, has been fixed, and things are good. But it's very important to identify this quickly. The boot-shaped heart of tetralogy of Fallot. And there's just another picture that actually shows you what's happening in tetralogy. You've got pulmonary stenosis, right ventricular hypertrophy, a ventricular septal defect, and an overriding aorta, which some people call dextro position of the aorta. It comes off to the right instead of the left. There you go, tetralogy of Fallot. Artifact, you just need to know what it is. You've seen it. Every time you do an EKG, you fight this stuff, right? Here's a patient cough. That's a type of artifact. Next is respiratory, next is the patient is shaking. Maybe they're too cold, for example, or maybe very nervous. That could be the case. Respiratory interference causes this wandering baseline. All those are artifact, and what that means is artificial. It's an artificial interference. It's not part of the patient's actual cardiac physiology. So those are examples of artifact. You could easily see something like that on your test. Axis deviation normally leads 1 and AVF are both upright. They're normally both upright on the 12-lead EKG. The electrical axis deviates toward hypertrophy. If there's an enlargement of a ventricle, for example, that will cause the axis to deviate toward the hypertrophy. If the axis deviates away, then that's probably infarction. The patient has actually had a heart attack, so there's less electrical activity in that damaged area. But let me just show you the pattern here. If leads 1 and AVF are both upright, that's normal axis. If you have a left axis deviation, then lead AVF is downward. And in a right axis deviation, lead 1 is downward. All right? That's going to take a little time on your part to digest and make sense of that. But you do need to know that pattern before taking your test. Metabolic alkalosis is famous for having low potassium levels with it. So if you're asked about a patient with metabolic alkalosis, a very common problem is low potassium, so you would need to supplement potassium chloride with that patient. Metabolic alkalosis, low potassium. Patent ductus arteriosus. I've got an excellent picture for you about this. This is where that ductus that is supposed to close at the time of birth has not closed. It's called patent ductus arteriosus. Very common finding, actually. And what we do to make the diagnosis of patent ductus is we measure the oxygen saturation preductal and postductal. Preductal, a good place to do that would be the patient's right arm. You could simply put an oximeter on a finger on the right hand, and then you would measure it on the feet for postductal, because that is after the connection of the ductus, which goes from aorta to pulmonary artery. Preductal, right hand, postductal, either foot. That is how you determine that that ductus is still open. Let's go back up here and explain. Right hand, preductal, either foot, postductal. And a cute little picture that somebody drew, not me. Methacholine challenge. Okay, this is where we think the patient has asthma, but we do a pulmonary function test and it's normal. So we want to actually cause bronchospasm. If you give histamine or methacholine to a patient who does not have asthma, then they won't have much change in their pulmonary function at all. However, give that methacholine or histamine to an asthmatic, and they'll have a significant change in FEV1, and anything more than 20% reduction is considered a positive test and the diagnosis is made. A 20% or greater reduction in FEV1 is how the diagnosis of asthma is made. That could very likely show up on your test. High flow systems. Definition of a high flow system is it must generate at least 60 liters per minute of total flow. That's enough flow to be sure that you are meeting the patient's inspiratory demand. A high flow device would be a Venturi mask, for example. I just noticed a misspelling on the review sheet. I want this to be as close to perfect a review sheet as possible. So an example of a high flow device would be a Venturi mask. It meets the total patient inspiratory demand. Example of a low flow device is a nasal cannula. Pitting edema. A student gave me this picture and I just love it. Pitting edema is where you push on the patient's ankle and the pit which is produced stays there. Typically this is congestive heart failure. I know you've seen patients with this scenario, but here you can actually see the different levels of pitting. 1+, 2+, 3+, 4+. It's easy to remember because the pitting edema level, double it and you get the millimeters of the actual depth of the pit. Pretty interesting. By the time the patient has 3+ or 4+ pitting edema, they may very well also have some pulmonary edema going on. All right, that is pitting edema. Dirty lungs or dirty chest. This terminology has appeared, and we really had to figure out what are they talking about. Cigarette smoking induced airway disease commonly results in increase in non-specific lung markings, which is probably early fibrosis, but we really don't know with certainty about that. It's just called a dirty chest. So if you see that, chronic bronchitis would probably be the likely diagnosis. And this will progress as the patient continues to smoke more over a period of time. This is an example of what you would call dirty chest. I think you'd agree there are more lung markings here than you would normally see. Dirty chest, smoking, chronic bronchitis. Number 235 is nitrogen dioxide. It is produced as sort of a side effect or adverse effect of nitric oxide administration. What happens is that the nitric oxide interacts with oxygen. The patient's going to have oxygen flowing, obviously, and we get some nitrogen dioxide produced. It's toxic. Levels greater than 10 are toxic. Our goal is to keep the level down below 2. So those are the numbers that you need to know. Toxic is above 10. Our goal is 2, but also you just need to know that nitric oxide interacts with oxygen to produce nitrogen dioxide. Number 236, a heat moisture exchanger. It's very handy. Let's be honest, an HME device, a heat moisture exchanger, is very handy for short-term use in adults. It's very handy for transport, okay? But it cannot be used in infants. There's just too much dead space. The tidal volumes are so small with infants, so just please know that we cannot use an HME with an infant. Here's the sweat chloride level. This is the classic test for cystic fibrosis. What we do is heat up the skin, measure the sweat chloride, and you will know if you have a cystic fibrosis patient or not. In kids, greater than 60 for the sweat chloride is positive. In adults, greater than 80 is positive. And there you go. Sweat chloride, the definitive test for cystic fibrosis. I actually took a picture here. Found a picture of a baby having the sweat chloride test. Okay, we know that FiO2s above 60 should be avoided whenever possible. But what actually happens with that FiO2 being higher than 60% over time? A lot of bad things happen. Chemical toxicity with pulmonary damage, retinal damage can happen, even in adults, definitely in kids, but even in adults. Problems with the erythrocytes, even the heart muscle can be damaged, and the glands. There are kidney effects, hepatic, meaning liver effects, and toxic effect on enzymes as well. So now you know why we go to PEEP instead of going up to 70% oxygen. All right. Independent lung ventilation, a couple students have mentioned this. This is where you ventilate each lung separately. Yes, you have to have 2 ventilators to do that, and you have to have a double lumen ET tube. This is useful if the 2 lungs are very different. And we give you some examples here. Massive hemoptysis on one side. Bronchopleural fistula might be a common thing that could cause this, the need for independent lung ventilation. Complications include bronchial trauma, laryngeal trauma, malpositioning of the double lumen tube. Sleep apnea, simple point, but you just need to know sleep apnea is 10 seconds, cessation of breathing for 10 seconds. Many patients have a 5-second pause from time to time. We're not worried about that. But a pause of 10 seconds or longer is sleep apnea. Okay, so many students have this type of question on their test. We don't know your exact question, but you need to know how to size the suction catheter for the ET tube. Here is the simplest way. Multiply the tube diameter by 2 and then go to the next smallest size catheter. So let's do several of those. A size 6, that's 2 times 6 is 12. The next smallest catheter is a 10 French, and that's what you should use for a size 6 ET tube. The 7 millimeter ET tube, 2 times 7 is 14. Next smallest catheter is a 12. The 8, 2 times 8 is 16. The next smallest catheter is a 14. That works, and it is exactly what we use at the hospital for those various tube sizes. Mixing nebulizer medications. Generally, we can mix medicines in the nebulizer, but there are certain times we shouldn't. For example, 2 medicines with the same mechanism of action. If a doctor would order, and I've actually seen them do this, albuterol with Xopenex, which is levalbuterol, you can't do that. Those are 2 medicines which act in the same way, and you could actually cause a serious problem for the patient by giving those 2 together. So you would have to politely decline and ask for a different order. Do not mix anything with Pulmicort because it causes foaming, which then interferes with nebulization, and the patient may not get their medicine at all. By the time that nebulizer is actually foaming, the particle size is not going to be correct, and the patient may not be getting their medicine at all. So don't mix anything with budesonide, Pulmicort, and do not mix ipratropium with cromolyn sodium. We don't give a lot of cromolyn sodium these days, but nonetheless, you cannot mix them. If you would happen to get that order, it causes a precipitate to immediately form. They interact and form a precipitate. Calibrating nitric oxide and capnography is too long a topic for this video. It would take up the entire video, but you need to know how to do it. So I have provided two links, one for nitric oxide, one for capnography, and these will show you how to do that calibration. Just review them before you go for your test. I am so excited to be able to give you this link. Number 244 is a 10 video series. So there's some time commitment, but you really learn how to read chest x-rays in doing this. About 10 minutes per video. I think the longest one is 15 or 16. It takes you step by step through reading chest x-rays, shows you all the most common x-rays that you might see appearing on your test. I really encourage you to do that. Number 245, patient with persistent hoarseness of the voice. We're concerned about that. That could be recurrent laryngeal or hypopharyngeal cancer. Recurrent laryngeal or hypopharyngeal cancer, persistent hoarseness. Patient taking birth control pills and presents to the ER with acute shortness of breath. Well, you probably learned in your training that birth control pills, oral contraceptives, are a known risk factor for pulmonary embolism. So if your patient is taking oral contraceptives, especially if they also smoke, the risk of blood clots in the lung, pulmonary embolism, goes up significantly. Also, you're going to see on your test, very likely, PFT results. And the thing is, you don't just need to interpret the PFT. You need to do that, which means finding out if it's restrictive or obstructive. But you need to know which diseases go with that. Okay, so restrictive pattern, which is a TLC less than 80, that could be pulmonary fibrosis, kyphoscoliosis, asbestosis, tuberculosis, any of those things. Restrictive. Obstructive pattern, that's the FEV1 to FVC ratio less than 70. This is likely asthma, emphysema, chronic bronchitis, could be any of the CBABE diseases. Therapist-driven protocols, just want you to review this. Protocols are predetermined, structured set of physician orders, instructions, interventions, in which the therapist is allowed to initiate, discontinue, refine, transition, or restart therapy as the patient's condition dictates. We don't have to have an order for every single thing we do if we have therapist-driven protocols. And the thing is, they're working. Hospitals that have this are finding lower cost, better outcomes for patients, even better discharge, quicker discharge and less readmission. Therapists know how to do this. We just need to be allowed. So therapist-driven protocols, we're definitely for them. They are working. It gives the therapist the ability to modify therapy as needed. Okay, the asthma classification guidelines are showing up on the test. These are from National Asthma Education Prevention Program, the VA, and GINA, which is the global initiative for asthma. Step 1 is intermittent asthma. Symptoms less than once a week, brief exacerbations, nocturnal symptoms not more than twice a month, and the FEV1 or peak flow is greater than 80% of predicted. This is not a very sick patient at all. Mild persistent, step 2, okay, symptoms more than once a week but less than once a day. More than once a week but less than once a day. Exacerbations may affect sleep. Nocturnal symptoms more than twice a month. And then the PFTs still greater than 80 with variability of 20 to 30%. Moderate persistent, daily symptoms. So you just think moderate, daily. Exacerbations may affect activity and sleep. Nocturnal symptoms more than once a week. Daily use of the beta-2, that would be the albuterol or something similar. The FEV1 has now dropped, FEV1 or peak flow 60 to 80, peak flow variability greater than 30%. And then severe persistent, where we have daily symptoms, frequent exacerbations, nocturnal symptoms, limitation of activities. The FEV1 or peak flow is now below 60, and the variability is greater than 30. And then here are the medications. Really for step 1, no medications are necessary. For step 2, then we would go to the low-dose inhaled glucocorticosteroid. That would be budesonide as an example. And you may go with theophylline, chromin, or leukotriene modifiers. For step 3, this would be the low to medium inhaled glucocorticosteroids plus your long-acting inhaled beta-2. Brovana would be a great example there. Okay, and then you would also have medium-dose glucocorticoids, inhaled glucocorticoids, beta-2 agonists, high-dose inhaled glucocorticoids, or medium-dose inhaled glucosteroids. All right, plus a leukotriene modifier. And then 4, this is your severe persistent asthma. This is where you hit them with everything. High-dose inhaled glucocorticoids, beta-2, theophylline, or some kind of theophylline product, leukotriene, long-acting oral beta-2, and oral glucosteroids. All right, folks, that's part 3 of our review sheet. I wouldn't be surprised if someday there's a part 4, and I will be happy to record that for you. This review sheet is making a difference. Students who took the exam before the review sheet existed and then used the review sheet extensively to prepare are scoring about 15 to 20 points higher on the TMC exam. That is getting a lot of them over the high cut so they can go on and become RRTs. Once you're an RRT in this country, your options are tremendous. So that's what we want you to achieve, obviously. All right. My name again, Deryl Gulliford, DERYL.GULLIFORD at independence.edu. My phone number is 405-219-6715. I can't always answer the phone, particularly in clinic, but I can receive a text and then respond to you. So I'm here to help. We only want you to pass this exam and have a great career.